Hello, I am Dr. Vikas Jain, and a brief introduction about me. I have done my medical schooling from MGM Medical College Indore. Then, after that, I entered into the critical medicine. I did my fellowship in emergency medicine from UK. Afterwards, I have done postgraduate diploma in diabetes mellitus, a full course of 2 years. After that, I did critical care medicines in Gangaram Hospital as well as Apollo Hospital. After that, I settled my clinic in Sector 11 Rohini and giving the treatment in the field of medicine, basically hypertension, cardiac, and diabetes. And now you all have given me the opportunity to speak about a case study and the discussion on it. So I am going to start my case presentation. It is a case of 53-year-old male, a corporate executive who was diagnosed diabetes 6 months back. When he came for the routine examination, he complained of profound weakness. He had a strong family history of hypertension and also had a family history of myocardial infarction. That means cardiac history is very positive. He was a heavy smoker for last 30 years, but he says he quit 5 years back and was now trying to lead a healthier lifestyle. He had a previous history of myocardial infarction 3 years back. On physical examination, weight was 92 kg, height was 5 feet 8 inches. That means BMI of 30.7. That means he comes in a obese category. His blood pressure was on the lower side, that is 90 by 40 millimeters of mercury. On lab examination, HbA1c was 8.4, which was said to be uncontrolled diabetes. Or he was dyslipidemic. LDL-C was 137, HDL-C was 37, and triglyceride level was 156. His renal functions were also deranged. His EGFR was 65 and urine albumin creatinine ratio was 50. From this, we can judge that he is having uncontrolled diabetes with dyslipidemia and having deranged renal functions. On taking his drug history, he was taking metformin 1 gram twice daily. For his blood pressure, he was taking telmisartan 40 milligram once daily. He was taking atorvastatin 10 milligrams OD for dyslipidemia. For blood pressure, he was also taking amlodipine 5 milligram. We can see that he needs a cardiovascular protection. He needs microvascular protection. He needs to decrease his weight. He has to reach a glycemic goal with no hypo or hyper events. That means he need a convenient dose schedule of maintaining his blood pressure, maintaining his diabetes. Primary consideration will be on cardio protection and to optimize the glycemic level and to address how he can reduce his weight. Going to my practice, I have been using this combination of SGLT2 inhibitor and DPP4 inhibitor combination since last 4 to 5 years, and I have received a very good result in this type of patients. That is a cardio-renal protection, and this is a simple regime, early and durable, achieving the glycemic control, weight loss, and no such events of hypoglycemia. Basically, the cardiovascular disease is a leading cause of morbidity and mortality in adults with type 2 diabetes, with its onset estimated to occur 12 to 15 years earlier in people with type 2 diabetes. That means a diabetic patient are more prone to have cardiovascular diseases. The excess risk of atherosclerotic cardiovascular disease in patients with type 2 diabetes has been estimated to be at least twice as those who are not having diabetes. There is a Framingham study which suggests that 2 or 3 of the patients of diabetes have subclinical cardiovascular diseases. Diabetes increases the risk of subclinical cardiovascular diseases by 4 to 3 folds. The vascular wall in the patient with diabetes is also to have advanced atherosclerosis. There is a trial of EMPA-HEART, empagliflozin on cardiac structures, functions, and regulating the circulating biomarkers, especially in type 2 diabetes. There is a EMPA-RED trial also which showed that there is a significant benefit of empagliflozin for cardiovascular mortality and CV events such as major cardiovascular events in type 2 diabetes and CV diseases. It has also been seen in the trial that all types of CV deaths were reduced with EMPA. More prominent like heart failure related death and sudden death were reduced. The post-analysis of EMPA-REG demonstrated consistent CV mortality benefit irrespective of CV events like MI and stroke, heart failure, CKD patients, and baseline HbA1c level. In this trial, we can just see that the patient whose case study has been discussed previously, it fits exactly in this category of trial. As he was having MI 3 years back and he was having reduced renal functions, his HbA1c was uncontrolled, though he was using metformin 1 gram twice daily. Several mechanisms have been proposed for CV effect of SGLT2 inhibitor, including osmotic diuresis and natriuresis, leading to lowering of the blood pressure, decreased arterial stiffness and vascular resistance, decreasing in weight, and decreasing in uric acid and oxidative stresses. This is a unique feature of decreasing the uric acid level when we are using empagliflozin in such patients who are having raised uric acid levels. It has been also reported that SGLT2 inhibitor promote reversing of cardiac remodeling. It improves myocardial energies and filling conditions, reduce the LV wall stress, and reduce the blood pressure and arterial stiffness. The EMPA Heart CardioLink 6 study demonstrated that EMPA could produce early reverse cardiac remodeling in type 2 diabetes and stable coronary artery diseases. It has also been seen that in Carmelina and Carolina trials, linagliptin has also demonstrated cardiovascular and renal safety. This trial was done in type 2 diabetes patients who were high risk of vascular complications. If these two drugs, EMPA and LINA, are combined together, it is the first class treatment, that is SGLT2 inhibitor and DPP4 inhibitor combination in cardiovascular and renal compromised patients. At 24-week study, it has been shown significant HbA1c reduction that has been very good if initially when the patient was only on metformin. HbA1c decrement by EMPA and LINA has demonstrated 1.81% HbA1c reduction at 24 weeks study. The combination offers a suitable component in strategy to achieve target HbA1c without any hypoglycemic agents and decreasing the weight of the patients and high baseline HbA1c level together with cardioprotective and renal compromised patients. Thank you.